Okay, welcome back, everybody. Today we have several chapters to cover. Let's see, we've got 19, 20, and 21, three separate chapters, but four separate lectures. So this is going to be a long one. Don't have anybody in yet, but if they come, I'll add them in. So let's go ahead and get started. We're going to start with chapter 19A, the somatic senses. Okay, here we go. Chapter 19A, the somatic senses. Okay, what are some sensory modalities that we talk about in anatomy? Well, there's different types of sensations. For example, there's touch, pain, temperature, vibration, hearing, and vision. These are some examples, not the full list. Each type of sensory neuron can respond to only one type of stimuli. So, for example, if you stimulate a temperature receptor with pain, nothing's going to happen. So the receptor that's specifically set up for that type of modality is the only one that will register when it's stimulated with that stimulus type. Okay, there's two classes of sensory modalities. The first is called general senses. When we say general senses, we mean the senses that are not localized to the head. So general senses mean throughout your full body. Special senses mean those found only in your head. So somatic general senses are sensations from the body walls. That is basically your superficial body. And the visceral general senses are sensations from internal organs. Often these are subconscious and cannot be felt consciously. The special senses, as I said, are those senses that are located in your head only. So, for example, smell, taste, hearing, vision, and balance or equilibrium. Okay, got another one of these weird repeats on the PowerPoint, but we'll get to it. All right. Sensory receptors demonstrate selectivity. As I said before, each type of sensory receptor responds to only one type of stimulus. If you stimulate it with a different type of stimulus, nothing will happen. So what are the events occurring within a sensation? Well, first, you have to stimulate the receptor with the appropriate stimulus type. Transduction or conversion of a stimulus into a graded potential. Now, in physiology, we'll go into the difference between a graded potential and a max potential. Basically, what's happening during a graded potential is as you stimulate the receptor, sodium gates are starting to open and sodium starting to flood into the neuron, and it's starting to be ready to be triggered into what is called an action potential. So the graded potential rises, the more you stimulate it to a certain level, it reaches what's called threshold, and then an action potential is generated. So generation of impulses or action potentials when the graded potential reaches and exceeds threshold. And then eventually there's integration of the sensory input by the central nervous system. That would either be your spinal cord for reflexes or your brain for more complex senses. Okay. We talked about selectivity already, so there you go again. Sensory receptors have simple or complex structures. So general sensory receptors, such as somatic receptors, you can have no structural specialization in free nerve endings that provide us with sensations such as pain, tickle, itch, and different temperatures. Those are not structurally specialized. And what we're talking about now is a neuron with free dendrites into the tissues. Now, some sensory receptors have some structural specializations in receptors for things like touch, pressure, and vibration. We'll look at that a little bit more in detail later on. The special sensory receptors, which are special sense receptors, often have very complex structures. The receptors themselves are not necessarily complex, but the structures associated with that sense are very complex. For example, vision, hearing, taste, and smell. A lot more complicated than some of the other somatic receptors. Okay, structural classification. Excuse me. So as I mentioned before, unspecialized receptors can be things like free nerve endings. And as I mentioned, bare dendrites extending into the tissues are what you would be using to gather the sensations or stimuli from the surrounding tissue. So free nerve endings give us the sensations such as pain, temperature, tickle, itch, and light touch. Some light touch. Some types of light touch do have encapsulated nerve endings or specialized receptors. More commonly, encapsulated nerve endings are found where dendrites are enclosed in a connective tissue capsule. And why would you do this? Why would the body have this? This is to reduce the sensitivity so that things like pressure, vibration, and deep touch are sensed, whereas light touch would be left to a different type of receptor. What about separate sensory cells? Well, specialized cells that respond to stimuli. Now, why do we say separate sensory cells? Well, most of these cells, neurons that are sensing stimuli in your body are neurons. They're regular neurons with a cell body, dendrites, an axon, etc. In the special senses, most of the cells that are doing the conversion of stimuli into what we would call action potentials, in reality, it's called a receptor potential. But the idea here is that most of these are not regular neurons. The only exception to that is smell. So for most of the special senses, there are special cells that are not neurons that are transducing the stimuli into signals that are interpreted by your brain as a sense. Okay, more classification. By location, now where would they be? So if we're talking about exteroreceptors as in external, they're found near the surface of the body. They receive external stimuli as opposed to anything happening inside your body. Things like hearing, vision, smell, taste, touch, pressure, pain, vibration, and temperature are all exteroreceptors because that's a stimulus coming in from the outside of your body to you, changing something about the receptor and sending a signal. Now, interoreceptors are different. They're monitoring what's happening inside your body, not due to outside changes, but due to internal changes that are happening as part of your normal living process. So interoreceptors monitor the internal environment, such as blood vessels or viscera, digestive organs, generally not conscious, or you can't tell what's happening, except when it becomes painful or the pressure becomes high. So for example, you don't normally notice your stomach unless there's a problem associated with your stomach that generates pain and pressure. Proprioceptors are another type. We find them near the joints. What they're really there for is to just give you information about the position of body parts so that you could put yourself in a particular position without having to look. Normally, we don't look to see what angle our arm or feet or toes are at. And the proprioceptors are what give us that ability to move ourselves in a way that allows us to tell the position of our body parts. Okay, classification by stimuli detected. Mechanoreceptors, as in mechanical, we're talking about changes to the shape or pressure of cells. So for example, touch, pressure, vibration, even hearing, believe it or not, proprioception, equilibrium, and blood pressure all are mechanoreceptors to change the sensing changes in the tissue shape. Thermoreceptors detect temperature, such as warmth and cold. Nociceptors detect damage to tissues. These are pain receptors. Photoreceptors detect light. Those would be the rods and cones in your retina of your eye. Chemoreceptors detect molecules in fluids. So, for example, taste, smell, and other changes to bodily fluid chemistry are sensed by chemoreceptors sensing chemicals. Okay, adaptation. What is adaptation? Well, adaptation in general means changing over time. And so when we talk about adaptation of sensory receptors, we're talking about a change in sensitivity of the receptor to a long-lasting stimuli. Now, long-lasting, in the case of many receptors, is 5-10 seconds, believe it or not. For the receptors, that's a long time. What happens is there's a decrease in responsiveness of a receptor. The receptor sends fewer signals because it becomes adapted to it. So one type is when you're in a room with an odor And it smells really strong when you first get there. And then you stop noticing it so much. And that is called olfactory fatigue, not old factory, the place you would make something. Olfactory means smell. Fatigue means wearing out. So if you've ever noticed, been in a room for a while, you stop smelling something unless fresh air is introduced again or the smell changes. We also have the cannibal pot phenomenon where we only notice changes in temperature and not overall temperature. And that's how sometimes people die in hot tubs, because they become adapted to the temperature of the water. And if it goes too high, it causes the equivalent of a fever. Your body temperature rises too much and you pass out and you drown in the hot tub. Receptors vary widely in their ability to adapt. Rapidly adapting receptors such as smell, pressure, and touch adapt quickly. They're specialized for signaling stimulus changes. So for example, light touch. Now, if you took your fingers and put them right on the surface of sandpaper and left them there, you wouldn't feel anything. I challenge you to try it. You have sandpaper in your house, put your hand on it and leave it right there, and eventually you'll stop feeling it. So what do we do to feel things that are rough or texture? We move our fingers across the surface of it, and that causes small fluctuations in where the bumps are felt. And so that's why they're rapidly adapting. Slowly adapting receptors mean this is a stimulus that your body expects to last a long time. So for example, pain and body position both don't adapt very, very, very rapidly. And for pain, believe it or not, that's good. You don't want your body to become used to pain, because then you will continue to injure that body part or use it, and you should be resting. Somatic tactile sensations, touch. It's the crude touch is the ability to perceive something that has touched the skin. And one of the reinforced sensory cells called the Pacinian corpuscles. And that senses more than light touch, deep pressure, vibrations. Discriminative or light touch provides location and texture of sources. So for example, Meissner's corpuscles are for light touch. Discriminative touch means less than deep pressure. What is pressure? Well, pressure is sustained sensation over a large area over more than just a moment. That's what pressure is. Vibration is rapidly repetitive sensory signal. That's how we're able to sense vibration. Itching is chemical stimulation of free nerve endings. Believe it or not, the same free nerve endings that generate pain. So pain receptors and itch are coincidental. That's why scratching and itch generating pain in that area is what relieves the itch. Tickle is stimulation of free nerve endings only by somebody else. Now, I added the by somebody else thing because really, if you're honest, you can't tickle yourself, because your brain knows you can stop anytime you want. The reason why tickling is disquieting or funny or whatever is because you are not in control of that sensation. If you were completely in control, it wouldn't really tickle anymore. And some people don't feel tickle. Some people feel it really a lot. But generally, you can't tickle yourself. I challenge you to try it. I don't think you can tickle yourself. Pain. Okay. Nociceptors are the pain receptors. They are free nerve endings found in every tissue of the body except the brain. And the question is, why not in the brain? Well, it turns out that the brain is the one place that's completely isolated from external sensation. It's really just a computer, a processor. It's not supposed to sense anything. Your brain doesn't sense anything directly. It's your skin and all of the other sensors that feed that information to your brain, where it makes decisions about what to do. So when you open up someone's cranium, touch their brain, cut it, whatever, there's no pain because there's no sensations. Now, it's not true for the meninges that surround the brain. The brain itself doesn't have any pain sensors. Pain senses are stimulated by excessive distension, that's stretching, muscle spasm, contraction, or inadequate blood flow, called ischemia. Tissue injury releases chemicals that stimulate nociceptors. So when you cut yourself or hurt yourself in some way, some of the chemicals found inside the cells that are damaged are released. They come across these free nerve endings, and that is sensed as pain. Very little adaptation occurs, as I said, because we want pain to last. I know that sounds very counterintuitive. The reason why pain doesn't adapt is because your body is trying to tell you stop using that body part. Because if it adapted and you didn't feel it anymore, you'd continue to walk on that broken ankle or cut foot, and it would cause even more damage. The fact that it also doesn't adapt very much also is a way of teaching your lesson, basically saying, hey, dummy, don't let that happen again. I'm going to punish you if you hurt yourself again with pain that's going to last a while. And so that teaches our brain to try to avoid pain for things that represent injury. Now, for example, giving birth does not really represent injury. So that kind of pain is not something that we try to avoid, women try to avoid, because if they did, they would have no child. So they're willing to do it again. And the same with something like a tattoo. That's something you choose. And so even though it hurts, it doesn't really represent an injury, although in reality it is injuring you. But you're not being injured in a way that you're out of control. So people will go back for tattoo after tattoo. Okay. Referred pain means feeling pain in a different area than it's actually occurring. So as you can see, the lung and diaphragm refer to the neck, but the most common, most cliche, is the heart referring down the arm. Now, why is this the case? Well, what is referred pain? It's visceral pain that's felt just deep to the skin, overlying the stimulated organ, or in a surface area that's far from the organ. If you look at some of these, liver and gallbladder, lung and diaphragm, very far away. Why do they refer there? Well, it turns out they share a common pathway. And the internal organ rarely uses it, and the surface of the skin uses it often. And so they just share a common pathway. So when you feel it, your brain interprets it as coming from the skin rather than from the internal part of the body. Heart attack is felt in the skin along the left arm since both are supplied by spinal cord segment T1 and T5. So because they're common, they go together as a single pathway, and because your heart almost never sends a pain signal, your brain interprets that as something from the skin. Your skin often sends pain signals. The real details of this we'll get into a little bit more. Muscle spindles. Stretching of the muscle stretches the muscle spindles, sending sensory information back to the central nervous system. That's triple. Okay. So that was 19A. So let's go to 19B. Where is it? There we go. Okay, I got a fly in here with me. Okay, now we're in 19B, talking about the special senses. And these are senses found only in the head, so nowhere else other than your head. So chemical senses. Interaction of molecules with receptor cells are what are called chemical senses. Hey, folks, give me just a moment. I need to kill this fly. I'll be right back. Sorry about that, folks. Had to kill that fly. It was driving me nuts. Okay, let's go with... Okay, this is where we were. We were talking about these special senses. Olfaction, or smell, and gustation, or taste. In Spanish, gustar means to taste, so that's a common Latin root. Both senses project to the cerebral cortex and the limbic system and can evoke strong emotional reactions, most pronounced with a sense of smell. A sense of smell, because it goes to your limbic system, generates a really strong emotional reaction when you smell something, especially if it takes you back in time. Okay, your olfactory epithelium. Now, here's an interesting factoid. This thing that we call our nose, the thing I'm touching right now, has basically nothing to do with our sense of smell. The olfactory epithelium, which is way up inside there, you see the purple area, that is what gives us our sense of smell. This thing that sticks out of our face has nothing to do with our sense of smell. There we go. The olfactory epithelium, which is shown here in the square, is about 1 square inch of membrane holding about 10 to 100 million receptors. Now, it seems like a lot, but dogs have 1,000 times more than that because they have the elongated snout, lots more olfactory epithelium, lots more of their brain dedicated to their sense of smell, and can therefore smell have a better sense of smell than humans do by many, many orders of magnitude. The area, it covers the superior nasal cavity and the cribriform plate. The cribriform plate is this little area here. If you've ever studied the bones of the skull and the inferior part of the cranium, the cribriform plate is this like holy looking little thin layer of bone. There's 3 types of receptor cells found in the olfactory epithelium. So we can see some of these cells here. There's supporting cells, olfactory receptor cells, and basal stem cells. The first type is olfactory receptors. They're bipolar neurons with cilia or olfactory hairs. These are the ones that actually sense the molecules that are coming into your nasal cavity and transducing those chemicals into impulses to your brain, telling you what you smelled. The supporting cells are columnar epithelium that basically give nutrients to these cells and hold them in place. The basal cells are stem cells that can divide to become the olfactory receptor cells or the supporting cells. Now, what's significant about this is one of the few sensory modalities where the sensory cells are almost directly in contact with the external environment. Also true for your sense of taste, but because we more or less choose what to put in our mouth and we kind of discerning about it, we tend not to put really awful things in our mouth out because we smell them first. But your sense of smell has none of that ability. Whatever's in the air, we smell it, and often if it's a toxic substance or something like chlorine gas, it can cause a lot of damage to these cells. And so these cells constantly are dying and needing to be replaced by the basal stem cells, which will then replace them with fresh, new olfactory receptor cells. Olfactory glands produce mucus, and you can see that here. This kind of reddish structure is going to be part of mucus because it needs to be a wet surface so the odorant molecules will stick to the mucus layer, dissolve into there, interact with these little hairs, olfactory hairs. That's what transduces into sense of smell. I will not be asking this figure on a test, so don't worry about that. All right, I mentioned adaptation. Adaptation is decreasing sensitivity over time. Olfactory adaptation is very rapid. About 50% of your sense of smell diminishes after 1 second. So when we first smell something, it's really strong. Then within a second or two, you don't smell it as much. And then within about a minute, you don't smell it at all. The only reason why we continue to smell smells at all is because the air is moving, often moving around, giving us different levels of odorant molecules. But best example of that is you go to someone's house that has pets, and it smells really strong when you get there. Within a few seconds, not so strong. Within a few minutes, you don't smell it much at all. Especially people who've been living there. If it's your house, you don't smell it at all sometimes. Our sense of smell is poor compared to mammals. For example, dogs have a nose that's 10,000 times more sensitive. When I say nose, I mean olfactory epithelium. This is why we use dogs for drug sniffing, bomb sniffing, etc., because they do have that long snout with a much larger olfactory epithelial membrane. And what do we use in this place? What's our dominant sense? Well, for dogs, it's mostly smell with hearing and vision being secondary. With humans, the reverse. Vision is number 1, with our sense of hearing being next, and then smell the least. And the question is why? Why do we have such a poor sense of smell? Well, think about where dogs are. Physically, they're down on the ground. That's where the odorant molecules are. Because over time we evolved into upright stance, we moved away from our odorants, our smells that are down on the ground primarily, and behinds. You guys know how dogs love to smell behinds. Because we're far away from that, our sense of smell diminished. And in place of it, we used our vision and hearing and all of our other senses integrated together with our large cerebrum, brain. Okay, gustatory sensation, taste. Taste requires dissolving of substances. So the idea is if you're going to taste something, it's got to be on a moist surface. So even if you dry your tongue out as best you can, putting anything on there is still going to dissolve in the moisture on your tongue. If you were able to completely dry your tongue off and then put something on the surface, you would not be able to taste it. Normally, we mix saliva with anything that we're eating so that those taste molecules can go in there. And most of the things that we think we're tasting We're not, we're smelling. So for example, strawberry is not a taste, it's a smell. The idea here is there's really only 5 tastes: sour, bitter, sweet, salty, and a last one that's not listed here called umami or deliciousness. So if it's not basic sour, basic bitter, basic sweet, or basic salty, or umami, everything else that we call a flavor is actually a smell. And one of the ways you can check that is when you can't smell very well. So for example, COVID, or when you have a cold, something like chocolate, which is normally delicious, because our sense of smell is diminished, it just tastes kind of waxy and sweet. So these are the only things we really taste. There's about 10,000 taste buds found on the tongue, soft palate, and larynx. The bumps that you see here, the filiform papilla, are not your taste buds. They're actually, if you look at these papilla, there's little grooves down the side of them, and the taste buds are found down there. This is significant because when you're eating something, tasting something, if you want to taste something fresh, for example, wine tasting, you have to rinse out your mouth to get all of those flavor molecules out of them so that when you taste the new thing, it's not mixing with the old. And no, I will not ask you to identify these regions on the test. And by the way, not everybody has this exact same map. This is a common map, but each person has a slight variation on this thing. What is the physiology of taste? Well, if you hold something in your mouth long enough, you can have complete adaptation in 1 to 5 minutes. Thresholds for taste vary among the 4 primary tastes. Most sensitive to bitter because bitter indicates poison. You don't want to swallow poison. So often when we taste something bitter, we regurgitate it or spit it out because it could indicate something poisonous. Least sensitive to salty and sweet. This is why we have to add so much sugar and salt to our food because we're less sensitive to it. And that's on purpose because our body wants us to get plenty of salt and sugar. Now, in the modern world, too much salt, but for our ancestors, getting enough salt was an issue. So being super sensitive to it wouldn't be helpful. Being less sensitive, then you had to add more to taste it, and then there you get more physiologically. As I mentioned before, most of what we call taste is actually smell. Approximately 75% of the taste of food is actually smell. So for example, when you get like a chapstick, flavored chapstick, it's not flavored at all. It just has an odor. It just fools your brain into thinking it has a taste. So if it's not sweet, salty, bitter, sour, you don't taste it, you're smelling it. Taste does not diminish with age, but smell does, and that causes some older folks to believe food has lost its flavor because they can't smell as well. Okay, vision. What are some accessory structures of the eye? The eyelids or palpebrae protect and lubricate the external eye. The tarsal glands, those tarsal glands, we see them here. Yeah, here they are, tarsal glands right here. Oily secretions keep your lids from sticking together, decreases the surface tension of the liquid. The conjunctiva, you've heard of conjunctivitis. It covers the inside of the eyelid and anterior portion of the sclera, so basically the 2 layers where your eyelid touches. It stops at the edge of your cornea. When the conjunctiva has dilated blood vessels, we call that bloodshot. And if it's inflamed or infected, it's called conjunctivitis. Okay, eyelashes and eyebrows. Eyeball is about 1 inch in diameter. We're going to see that 1 inch size in a lot of anatomical parts coming up later in the lecture. 5/6 of the eyeball is found inside the orbit and protected, so only 1/6 of our eye is actually visible outside of our eyelids. Eyelashes and eyebrows help protect the eye from foreign objects, perspiration, and sunlight. So it keeps dust out, sunlight from damaging the retina, etc. Sebaceous glands are found at the base of the eyelashes. These are oil glands that keep your eyelashes flexible. If there's an infection of those sebaceous glands, it's called a stye. Relatively rare because the tears containing an enzyme called lysozyme that kills bacteria would give you the infections or a stye. The lacrimal apparatus is what's shown here in green. It's about 1 milliliters of tears are produced per day. They're spread over the eye by blinking. Contains bacterial enzyme called lysozyme. I mentioned that. It's one of the reasons why we generally don't get eye infections when we're old enough. Newborn kittens get this more often because they're not producing much lysozyme until they get a little bit older and they can start killing the bacteria. And one of the reasons why mother kittens lick their baby's eyeballs or eyelids is because the saliva in the mother kitten's mouth on her tongue does contain lysozyme and does help kill the bacteria that would be causing potential eye infections of the newborn kittens that haven't opened their eyes yet. I will not ask you to describe this figure for the test. Okay, extrinsic eye structures. We're talking about things on the outside of the eyeball. There's six, extrinsic eye muscles. All right, 6 muscles that insert on the exterior surface of the eyeball. They're the most precise muscles in the body. They have a 1-to-1 ratio of motor nerve to muscle fiber. We talk about that a lot in physiology. It just means that your eyes can move in very precise ways that wouldn't be possible with larger muscles like your gluteus or quadriceps. There are 4 rectus muscles. The term rectus means straight down the middle. And those would be the superior on top, inferior on the bottom, lateral towards the center, and medial towards the sides. They use to turn the eyes. And when we mean turn the eyes, it means looking without moving your head. So you can look without having to move your head. There are 2 oblique muscles that move in an angle. They basically rotate the eye like this so that you can center your vision better. Okay, the tunics are layers of the eyeball. This is what the cross-section of an eye looks like. The fibrous tunic or outer layer is this white structure that you see here. The vascular tunic is the middle layer that contains the blood vessels, why it's called vascular. And then the nervous tunic, the inner layer, is your retina primarily. Okay, the cornea is the curved, clear bubble on the outside of your eye. The clear anterior portion of the external tunic or sclera is your cornea. It's transparent. It helps focus the light, refracts light by bending it. Now, an astigmatism means the curves of the cornea are not balanced. So, for example, the curves that go this way don't match the curves that go this way, front to back and left, right, don't have the same. So if you wear contact lenses, the astigmatism is a measure, something that has to be built into the contacts, as well as any lenses that you wear on the outside. Transplants, corneal transplants, they're common and successful. Now, why is that significant and different? Well, most body parts that are transplanted in have a whole bunch of blood vessels going to them, and the body's immune system senses that that organ, say a heart, belongs to somebody else and not you. Well, because the cornea doesn't have blood vessels, it's not getting a lot of immune cells to it, and so getting somebody else's cornea usually is pretty successful because there aren't a whole lot of immunoglobulins heading there and white blood cells there checking it for self versus non-self. It's nourished by tears and aqueous humor. So the tears are out from the outside, and aqueous humor would be found right in this gap that you see here. It's kind of like a mushroom on the belly. Okay, the sclera, it's the white of the eye. It's made of dense, irregular connective tissue layer containing both collagen and fibroblasts. Provides shape and support. This is what gives our eye the structural support, keeps it from collapsing. Okay, the vascular tunic, the choroid and ciliary body. The choroid is a pigmented layer of epithelial cells, melanocytes, the same kind of cells that we find in our skin that give that color, and blood vessels. The choroid provides nutrients to the retina. The black or dark brown pigment in the melanocytes absorbs light after passing through the retina. That means light comes through, and if it doesn't hit one of our sensory cells, it's absorbed by the pigment. Now, animals that have to be awake and alert at night have a structure called a tapetum lucidum, which reflects light because they have to be able to see really well in the dark. We don't, because we're normally asleep when it's dark, or we have external artificial light, so we don't need that reflective layer. We're adapted for daylight vision. Next is called the ciliary body that contains the ciliary processes. What do? They secrete the aqueous humor into the anterior chamber. The anterior chamber is everything on the front of the lens. The ciliary muscle is smooth muscle that alters the shape of the lens. So the lens can go from fat to flat. So this is what your lens looks like when looking at far away objects. And this is what it looks like when you're looking at near objects. Now that's only for people who are young, people like me, who want to see up close, have to wear reading glasses because our lens won't bend anymore. I'll talk a little bit more about that later. Okay, the iris and the pupil. The iris is the colored portion of the eye. For many people it's blue, for some it's brown, vice versa. Actually, more people have brown eyes than blue. It's the shape of a flat donut. It's suspended between the cornea and the lens, and that's what you see, this ridged area here of muscle, colored part of the eye. The hole in the center is the pupil. And what is the function of the iris and the pupil? Is to regulate the amount of light into the eye. So it's really bright, the pupil shrinks to a much smaller point, and when it's dark, it opens up, allowing more light through. Autonomic reflexes, the circular muscle fibers contract in bright light to shrink the pupil, and radial muscle fibers contract in dim light to enlarge the pupil. And how that works is here. Okay, so if you're in bright light, the circular muscles contract, squeezing down the hole. But when it's dark, the circular muscles relax and the radial muscles, which are pulling outward, contract, opening it up. So it just depends on which set of muscles is contracted. I will not ask you about this figure on the test. Okay, the vascular tunic. It's avascular, meaning there are no blood vessels in the vascular tunic. I know, let's see what we got here. Okay. So the vascular, it sounds a little counterintuitive, I realize. So we're talking about the lens. It is part of the vascular tunic, but the lens itself doesn't have any blood vessels. So even though it's part of the vascular tunic, it is not vascular itself. The cells receive nutrients from the aqueous humor. That's that liquid that's produced here. There'd be both oxygen and nutrients there, and the waste would be removed and sent out through the canal of Schlemm. They're crystalline proteins in the lens arranged like layers of an onion. Their job is to bend to change the focal length of the light. The lens is held in place by suspensory ligaments that you see right here, and it focuses the light on the fovea, or fovea centralis, which is in the center of a region called the macula. You may have heard of a thing called macular degeneration. That's where that very important part of our retina could start losing its ability to sense light. Okay, the nervous tunic. Now, if you look into somebody's eye, this is what you might see as an image. This is what an optometrist or ophthalmologist would see when looking in through your eye to the back of your eye, which is retina, and the blood vessels of your choroid. All right, so the retina is the posterior 3/4 of the eyeball. The optic disc is the blind spot. It's where optic nerve fibers converge and exit out the back of the eyeball. So this area where the optic disc is, you can't see in that area at all, but our brain kind of pretends like it doesn't exist and overlaps it with the other eye. Even when you close one eye and look out the other eye, you can't see the blind spot because your brain fills in that blind spot with surrounding information. Okay, the central retinal blood vessels, BVs here, they fan out to supply nourishment to the retina. The retina is nerve cells and sensory cells that require a lot of oxygen and nutrients. And it's visible for inspection, checking for things like hypertension and diabetes. One of the things that you can see when looking at these blood vessels in the pattern. A detached retina can be due to a trauma, such as when you hit your head. Like so, getting hit with a boxing glove would push your head backward, intending to detach the retina. And the same thing if you got into an accident and you hit your head, could cause a detached retina. What happens is fluid accumulates between the layers, that is between the choroid and the retina. That separates the retina from its blood supply of nourishment, and it begins to die. This can cause distortion or blindness if this happens. All right, rods and cones. These are the cones, the green things, because they look kind of conical. Excuse me. Yes, cones. Cones, they look conical. And the rods are more rod-shaped, more cylindrical. Okay, rods are rod-shaped. Their job is to sense shades of gray and dim light, so these are active when it's darker out. We have fewer of these. We have more of the cones than animals like dogs, cats, and other nocturnal animals. Nocturnal animals have mostly rods. We have mostly cones, especially in the area where we're looking at something of interest. So the rods sense shades of gray. They discriminate shapes and movements. We can, basically, a lot of our peripheral vision is full of that, and often distributed outside the macula. So almost all of our peripheral vision, believe it or not, is shades of gray. But we don't notice it because it's peripheral vision. As soon as we look at it, our macula, which contains cones, is focused on it, and then we see the color. Cones are cone-shaped. They're used for sharp color vision, but it requires brighter light. So we tend to use the cones in daylight or rods at night. The fovea centralis, or fovea, of the macula lutea is the center of our greatest visual acuity. It's a densely packed region of cones at the exact visual axis of the eye. That means if you go straight back from the center of the eye, right there at the very back, as in a straight line, is your fovea. It gives us the sharpest resolution or acuity, and this is where an image of text or a person's face or something of great interest would be sitting if we were looking at it. Okay, pathway of nerve signals. It's a little bit weird, and it's backwards. So normally you would have the sensory object in front and then the nerves moving backward towards the brain. This is the way it is in every other part of the body. The sensory cells are closest to the stimulus, and then the nerves lead backwards towards the brain. Well, in the eye, it's the opposite. You can see the pathway of light is from bottom to top, and yet the sensory cells are way here in the back, so that the light has to pass through all of these cells. Now, in the body, in reality, they're clear, they're colored here for clarity, ironically, to make it more easy to see. But light would pass through all of these, strike these rods and cones, and then the signal would come out through the front and go across the surface and eventually make its way out through the optic disc or blind spot. And that's why you can't see there, is because it's just a whole bunch of cables leading the signals out. And if you have cables there, you can't have sensory cells. Light penetrates the retina, as we said, from low to high. The rods and cones transduce or convert light into action potentials. The rods and cones excite what are called the bipolar cells. You can see the bipolar cells are right here, the blue. The bipolar cells excite the ganglion cells, and these are the ganglion cells. Now the axons, which are the outgoing processes of the ganglion cells, form the optic nerve that goes all the way back to the part of your brain that senses light. Eventually through the thalamus and then the primary visual cortex of your cerebrum. Okay, so what are some of the cavities of the interior of the eyeball? The anterior cavity is everything you see in blue. So this is everything between the cornea and the lens. That's the anterior cavity. Now, the anterior cavity is actually separated into two chambers. It's a little confusing. I'll clarify. Everything in here is filled with what is called aqueous humor. Aqueous means water. So this material is water. It's basically like water. It's produced by the ciliary body that I mentioned earlier, and is continually drained and replaced. It's replaced every 90 minutes. Now, why does it need to be replaced so often? Well, remember, this is how the cornea and the lens receive the nutrients, the oxygen and the food they need to survive. So if it were stagnant in there, the cells would die. So it's constantly being replaced with fresh aqueous humor that contains oxygen and food. Now, there's two chambers of this anterior cavity. The anterior chamber is the front part of the anterior cavity. The posterior chamber is this little tiny potential space between the iris and the lens. Now, the posterior cavity is everything behind the lens. You can see this big blue here, and that's dominated by what is called the vitreous body or vitreous chamber. It's filled with the vitreous body, which is jelly-like, and it's formed once during embryonic life. So this isn't replaced because all the cells behind it have access to blood vessels, nutrients, and oxygen. So the whole front of your eye does not have blood vessels because that's the pathway of light. You can't have blood vessels running through the lens or the cornea that would block the light. The red blood would block the light. So all of these structures get their nutrients from this fluid, whereas all of the cells on the back of the vitreous chamber receive their blood, their nutrients through blood vessels. Okay, more about the aqueous humor. It's continually produced by the ciliary body, as I mentioned. It flows from the posterior chamber into the anterior through the pupil. So it's made back here, it goes past the lens and loops around to the front, and then eventually makes its way out through what is called the canal of Schlemm. Now, the drainage of the aqueous humor goes through the canal of Schlemm, one of my favorite words in anatomy. The opening in the white of the eye at a junction between the cornea and sclera. Basically, it's a drain for the aqueous humor. Now, in glaucoma, increased intraocular pressure can produce blindness because this fluid is not draining. So as the fluid is being produced, it can't exit, and that high pressure can put pressure on the blood vessels and the retina, causing blindness potentially. So sometimes they put in what's called a shunt. Sometimes they prescribe marijuana. Marijuana actually opens up this canal of Schlemm. So sometimes people with glaucoma are prescribed THC so that they can decrease their glaucoma. Okay, processing of the image data in the brain, visual information in the optic nerve travels to the occipital lobe, which is on the back for vision. Another irony is our visual lobe isn't by the eyes, it's way in the back of our head. The midbrain is for controlling pupil size and coordinating head and eye movements, and the hypothalamus is to establish sleep patterns based on circadian rhythms of light and darkness. What do we mean? Circadian rhythms. Even if somebody is denied access to the sun and light, you can kind of tell when dark and light are happening because our body has an internal clock. That's what the circadian rhythm means. Okay, chapter 20, part 2. Let's see, review questions. We're not doing that. So I think, okay. I had to skip some, skip some slides because those were review questions that are not our review questions. So let's go back to it, to the area. Here we go. Okay, moving on to the ear. All right, the ear is another special sense. This shows you the basic anatomy. You have your external auditory canal, the middle ear, which contains the malleus, incus, and stapes, and your inner ear contains the cochleus and the semicircular canals. The external ear. What is the function of your external ear? It's to redirect sound waves to determine directionality. Now, the text may say, this thing on the side of your head is for focusing sound waves into your ear tube. It is not. Only the part that you can touch with your finger right in the center here does that. All the rest of this is to just determine directionality, to give us above and below in terms of sound. I will not ask you about the ears of humans and animals being different, so you can skip that. What are some of the structures? The auricle or pinna is the thing that sticks out the side. It contains elastic cartilage covered with skin. Flexibility means that if you're sleeping on it or press against it, it's not going to break. It's a fragile structure. So elasticity is key. The external auditory canal is a curved 1-inch tube of cartilage and bone. Remember that 1-inch size again. Leading through the temporal bone. This B is bone. Ceruminous glands are wax glands, produce cerumen or earwax. And the earwax is there to reduce the growth of bacteria so you don't get an external ear infection. Now that happens more commonly when we let water accumulate in there. And so sometimes you get what's called swimmer's ear if water stays in your external ear. Normally, if you wipe it out or knock it out by tilting your head or putting alcohol in there, it's rid of it before the bacteria. The tympanic membrane is the end of the external auditory canal or eardrum. Tympanic membrane is the better term because it's scientific. Sound waves cause the tympanum to vibrate, which moves the inner ear bones. BB is bones, by the way. If there's a perforated eardrum or a hole in the eardrum or tympanum, at the time of the injury, you could feel pain, ringing, hearing loss, or dizziness, and can be caused by explosions, scuba diving, or ear infections. Ear infections, the bacteria can eat through the tympanum. Scuba diving, failure to equalize can cause pressure to burst the eardrum, or explosions or loud, sometimes really loud noises can cause the eardrum to be damaged. Okay, the middle ear cavity. Now, when people say they have an inner ear infection, they don't really mean that. They mean they have a middle ear infection. Now, why is this the case? Well, it turns out the only part of your ear that's really exposed to your throat where bacteria that could cause infection is the middle ear cavity. You can see the auditory tube here actually leads to the back of your throat. So if you're ever in a car and you're going up a mountain, sometimes you open your mouth real wide, open the little exit to the auditory tube, and it'll let the pressure equalize. But if bacteria come from your pharynx, the back of your throat, up through the auditory tube and start growing in here, this is what's called a middle ear infection, because this is your middle ear. Generally doesn't happen in the external ear because of the cerumen or wax. Can't happen in the inner ear because it's not connected to anything with bacteria. So kids often get infections here because their auditory tube, instead of being angled downward like this, is more horizontal, allowing the bacteria to swim in more easily than swimming upwards in adults. Okay, the middle ear cavity. It's an air-filled cavity within the temporal bone. It's separated from the external ear by the eardrum and from the internal ear by the oval and round window of the cochlea. I'm going to be showing you those here in a bit. There's 3 ear ossicles, which mean tiny bones. The malleus is attached to the eardrum. The incus is attached to the stapes, and the stapes is attached to the membrane of the oval window. So these 3 bones are connected together. The auditory or eustachian tube or pharyngoauditory tube leads to the nasopharynx, basically the back of the throat, just a little bit above your mouth. It helps equalize the pressure on both sides of the eardrum, especially during changes in altitude or depth underwater. So scuba divers, or anybody who's diving into the water, if they want to go down further, what they do is they have to pinch their nose and blow some extra air into that middle ear cavity. So the pressure on the outside pressing from the water is equal to the pressure on the inside, and the air you press inside there. Okay, this shows you some of the muscles of the middle ear. The stapedius muscle inserts onto the stapes, hence the name, prevents very large vibrations of the stapes from loud noises. So whenever there's a really loud noise, the muscle pulls on the bones, keeping this whole system more stabilized so you don't damage the sensitive hair cells in the cochlea. The tensor tympani attaches to the malleus, which is attached to the tympana. It also limits movements of the malleus and stiffens the eardrum to prevent damage. So whenever a really loud, sustained noise happens, these muscles pull in the same way that if you put your hand on a drum, it would stop moving, or on a speaker cone, it would stop moving. So by pulling on these muscles, it prevents the system from sending too much information, too much vibration into the cochlea and damaging the hair cells. Okay, now the next thing that we're going to be talking about is the bony labyrinth of the inner ear. Everything here, the vestibule and semicircular canals, has nothing to do with your sense of hearing. It has everything to do with your sense of equilibrium or balance. All right, the semicircular canals are involved in rotational acceleration. So when you turn your head like this or are spinning, you would sense it in the semicircular canals. The vestibule here contains structures that help you orient up and down, and gravity, sense gravity. The bony labyrinth is a set of tube-like cavities in the temporal bone. The semicircular canals, vestibule, and cochlea are filled with a liquid called perilymph, sometimes called endolymph. It surrounds and protects the membranous labyrinth, which lines the inside of all of these cavities. Okay, so if we talk about the membranous labyrinth being kind of like a maze. It looks kind of like a maze if you were in there. So as I said, the vestibule and saccule, right here, this is involved in sensing gravity, and then the posterior, anterior, and lateral semicircular canals are involved in rotational acceleration. And there's 3 of them because there are 3 planes of movement. So you can either move this way, your head going this plane, you can go laterally, doing this very well, kind of spinning this way, or you can turn this way, as I am on my chair. So these are 3 different planes of movement, each sensed by one of the different semicircular canals. The membranous labyrinth is a set of membranous tubes containing sensory receptors for hearing and balance, and are filled with endolymph. Perilymph is another name for it. Sometimes they give them different names depending on their location. So there's 3 different areas: the apical, saccule, and ampulla. 3 semicircular ducts and the cochlea all make up the membranous labyrinth. Okay, a little bit more about cochlear anatomy. There's 3 fluid-filled channels. You can see them here, 1, 2, 3. Found within the cochlea, the scala vestibuli, scala tympani, and the cochlear duct. Vibration of the stapes upon the oval window, which you see right here, the stapes touching the oval window, sends vibrations into the fluid of the scala vestibuli. The scala vestibuli is this one right here. Okay, I may ask you to describe this process. It's really, really important to take good notes here, because I'm going to be asking you more than what is seen on this figure. I'm not just going to ask you, how does the process of hearing work, but how do we discern pitch and volume? So make sure that if this comes up on the test, you not only tell me these 5 steps, but how we sense pitch and volume. So fundamentally, I'm going to go through the basics, then I'm going to talk about pitch and volume. Step 1, the pressure waves, which we call sound waves, strike the tympanum, and they cause these bones to move. The bones change the high amplitude movement of the tympanum into less magnitude, greater force movements, and the greater force movements that are transferred into what is called scala vestibuli, or vestibular cavity tube. These vibrations then go from being in the air, in the bone, to the liquid, and they start vibrating through here. When they get to this area here, let's say a particular region of the cochlea that matches the pitch of the sound, it causes this area to move. The movement of these causes hair cells to bend. When the hair cells bend, they send signals through the cochlear branch of cranial nerve 8 to basically your cochlear nerve, and it's interpreted by your brain as sound. Then when this movement happens, it pushes outward and causes the round window to bulge out. So as the oval window pushes in, the round window pushes out, and it goes like this. Because fluid is not compressible, when you push in on a fluid, it has to have a place to push out. So as it's going this way, the other one is going kind of the opposite direction. Now, the next thing I need to tell you about is how we determine pitch and volume. And this is where I'm going to be asking you to be able to do this on the test. So for pitch, it has to do with what part of the cochlea is being stimulated. Write this down. Sounds that are high-pitched sounds, kind of like a kitten meowing, or a screech, something really, really high-pitched, would cause this proximal part of the cochlea to move. If it was a medium-pitched sound, like my voice, it would cause the middle of the cochlea. If it was a very deep sound, like a bass drum, it would cause the very end to move. And so your brain interprets sound, the pitch of sound, not by how fast these waves are coming through, but what part of the cochlea is moving. So you can think of it very much like a piano. One end of a piano has high notes, the middle has middle notes, and the other end has deep notes. And you can't go to one end and make it sound a completely different way by how you hit it. A pitch notes are always going to be at that end of the piano. So if this part of the cochlea is moving, it's going to be a high-pitched sound. If this part is moving, it's a middle-pitched sound, and the far end is low-pitched sounds. And this is how we determine pitch. What part of the cochlea is moving? What part of the cochlea is sending signals? So it's not the frequency of the waves that is sensed directly. It's what part of the cochlea is moving. Now, for volume. At a particular spot, a loud sound is going to make more hair cells be stimulated, and each of those hair cells is going to be sending more signals per second. This is how we determine volume. So when I ask about this in I'm not asking what is volume, decibels. I'm not asking what is pitch, but how does your cochlea determine pitch and volume? And I just told you. So take notes, rewind, watch this again. If I ask this, I'll be asking for that. And if you don't tell me about pitch and volume and tell me only about what you see here, it's not worth full credit. Okay. All right. A section through one turn of the cochlea. So if we slice open the cochlea, we see the scala vestibuli contains perilymph, scala tympani contains perilymph, and the cochlear duct contains endolymph. So it's really kind of the same fluid, but if it's here, it's called endolymph. If it's here, it's called perilymph. Really not any significant difference. But the idea is waves come through here and then out through here. It causes this whole system to start moving, and these two layers start smashing into each other. As you can see, there's a layer called the tectoral membrane right above the basilar membrane. If they start smashing into each other, the little hairs there start to bend, and the hairs bend, they send a signal, which is interpreted as sound. The partitions that separate the channels are Y-shaped. You can see kind of a branching here, looks like the letter Y. Fluid vibrations bend hair cells in the cochlear duct, generating action potentials, and the action potentials come out through here, through the vestibulocochlear nerve, which eventually becomes the cochlear nerve. Okay, if we look a little bit closer at the organ of Corti, which is that little area in the center where the vibrations are causing action to happen. The tectoral membrane is going to stay still, but the basilar membrane is going to start bouncing up and down like a trampoline as sound waves or pressure waves move through the fluid. When the pressure waves move through, this whole basilar membrane starts rising up and down, and you can see the hair cells that are sticking up start to get deflected downward like this. When that happens, changes to the membrane potential of these hair cells happens. They release neurotransmitters to these fibers of these nerve cells. And when that happens, action potentials are generated. So when fluid waves come through here, bounces up and down, strikes the tectoral membrane, hair cells bend, release acetylcholine or other neurotransmitters, and that sends a signal out. And that's what we interpret as sound. About 16,000 hair cells have 30 to 100 stereocilia, which are actually microvilli. The microvilli make contact with the tectorial membrane, which is a gelatinous membrane that overlaps the spiral organ of Corti. And the basal sides of the inner hair cells synapse with first-order sensory neurons whose cell body is in the spiral ganglion. So the spiral ganglion is going to be down here. So these are basically sensory fibers. And when the inner hair cells release the acetylcholine, that causes action potentials to transfer all the way to the brain, be sensed as sound. Okay, what is a sound wave? Well, a vibrating object causes compression of the air around it, which is sound waves. Audible range is between 20 to 20,000 hertz. We hear best between 500 and 5,000 cycles per second hertz. Speech is between 100 and 3,000 hertz. The frequency of a sound vibration is pitch. So when we talk about the pitch of a sound is how many cycles are happening or waves are passing in a given moment. Greater intensity or size of vibration, the louder the sound measured in decibels. Now, that's what volume is. This is what pitch is. But earlier I talked about how do we sense it in our cochlea. On the essay, don't tell me what pitch is. Don't tell me what loudness or intensity of sound is, but how do we interpret it in our cochleas? Conversation is approximately 60 decibels, and above 140 decibels, it starts to hurt. And so the OSHA, which is Occupational Safety Administration, requires ear protection, for example, ear muffs or ear plugs in any job above 90 decibels because you don't want your eardrum or your hair cells, your cochlea, to be damaged. And too many rock concerts can cause a lot of damage to the hair cells. Deafness. What are some different types of deafness? Well, nerve deafness is when there's damage to the hair cells due to antibiotics. And yes, antibiotics can cause damage to your sense of hearing. High-pitched sounds or high volume of sounds. Certain anti-cancer drugs can kill the hair cells. The louder the sound, the quicker the hearing loss. So if you are listening to really, really loud sounds like music, a lot, you're going to have a lot of damage. And interestingly, in us, those hair cells don't regenerate. In birds, they do, but in humans, no. So when you lose your sense of hearing due to nerve deafness, you're not getting it back. But birds, because they rely so much and their sense of hearing do regenerate their hair cells. Often we don't even notice until difficulty with speech. My mom is in her 80s. She has difficulty hearing, but she doesn't want to wear a hearing aid because it's a pain in the neck. Anyway, conduction deafness is another type of deafness. This is when the conduction system between the eardrum and the cochlea is damaged somehow. So, for example, a perforated eardrum, a hole in the eardrum, could be a conduction problem. Or otosclerosis. Now, otosclerosis means the little bones that are bending like this, when we hear, become stiff, kind of like our fingers become stiff with age. And if they don't bend as much, we don't transfer the sound as well. So you need louder sound. So as people age, those bones become less flexible, transmit the sound, the vibration less, and therefore need more intense sound to still hear. That's what hearing aids are for. All right, physiology of hearing. The auricle or pinna collects sound waves. Now, it says that, but really most of this thing is for determining directionality. And I think if there's an article available on what's a pinna for, it comes up as extra credit. Okay, when the eardrum vibrates as a result of these pressure waves striking it, slow vibrations are in response to low-pitched sounds, and rapid vibrations in response to high-pitched sounds. The ossicles or middle ear bones vibrate since the malleus is attached to the eardrum. The stapes pushes on the oval window, producing fluid pressure waves in the scala vestibuli and scala tympani. That was that picture I showed you. The oval window vibration is 20 times more vigorous than the eardrum. So, for example, I did tell you that those bones decrease the amplitude, but increase the power. So the total movement is decreased, but the power of the movement is much greater because of the increased density of fluid in your cochlea versus air. Sound waves through air, much easier to pass. Sound waves through liquid, much more difficult. So you're trying to transmit sound waves or vibrations from air to liquid, you have to get more power to. The microvilli are bent, producing receptor potentials. Receptor potentials turn into the release of acetylcholine, which strikes those first-order sensory cells. Those generate active potentials, which are transmitted to the brain as sound. Okay, so these are those same steps I showed you, just a little bit more detail. So this picture may be there, but I already went through these different steps: pressure waves, eardrum moving, ossicles moving, transmission of vibrations to the scala vestibuli, the movement of the basilar membrane, tectoral membrane, and then the outward movement here at 9. Don't forget about how we sense pitch and volume. Pitch is what part of the cochlea moves, and volume is how many hair cells are stimulated and how often they send signals. More signals, more loudness. Okay, how do we distinguish different sounds? Sounds at different frequencies vibrate different portions of the basilar membrane. High-pitched sounds vibrate the stiffer, more basilar portion of the cochlea, as I mentioned. Low-pitched sounds vibrate the upper cochlea, which is wider and more flexible. Loud sounds cause a greater vibration of the basilar membrane, stimulate more hair cells, which our brain interprets as louder. Not only are more are stimulated, but they also send more signals. So that's how we interpret volume is not just by how many hair cells are going, but how many signals they're sending per second. The frequency of action potentials correlates to volume. The frequency of the sound is transmitted to location on the cochlea. It's a little counterintuitive. You guys can get it. All right, balance. How do we stay in balance? Well, static equilibrium, how do we sense gravity? It helps us maintain the position of our body, really our head, relative to the force of gravity. Macular receptors within the sacral and utricle allow us to sense gravity because they're basically little crystals that move relative to gravity in our head. Now, dynamic equilibrium means spinning, our ability to sense spin. It helps us maintain body position during sudden movement of any type, rotation, deceleration, or acceleration. Crystal receptors within the ampulla of the semicircular ducts help sense the fluid moving through it. The details of exactly how we sense rotational acceleration I'll give you in physiology. So as this fluid moves, we can sense that our head is moving. And then when we stop, the fluid's still moving, so sometimes it feels like we're still spinning after we stop. The semicircular ducts with ampulla, utricle, and saccule. Everything in orange is associated with sense of sound, everything in pink associated with equilibrium. Okay, a little bit more about the saccule and utricle, our sense of balance. Now, these are called otoliths, which means ear rocks, and you actually have little tiny rocks inside your head. These rocks, or otoliths, are heavier than the surrounding fluid and respond to gravity. It's thickened regions called the macula within the saccule and utricle of the vestibular apparatus. Now, notice there's a macula here. This is different than the macula in our eye, unfortunately, same name. What are some different cell types in the macular region? Hair cells, like we saw in our sense of hearing, there's stereocilia, which are actually microvilli, and one cilia, or kinocilium. They're supporting cells that secrete the gelatinous gel you see here. The gelatinous otolithic membrane contains calcium carbonate crystals called otoliths that move when you tip your head. So I'll show you how this works. So when your head is upright, these otoliths are little tiny rocks embedded in the gel are sitting still, and the hairs are straight up and down. When you tilt your head forward, the force of gravity pulls on these little crystals, bending these little hairs, which sends a receptor potential to these neurons. And if you tilt your head one way, the bluish ones will be stimulated. You tilt your head another way, the red colored receptor cells will be stimulated, hence giving you the difference between forward and backward. The movement of the stereocilia, stereo meaning both directions, or kinocilium, results in the release of neurotransmitter onto the vestibular branches of the vestibular cochlear nerve. Okay, so for rotational acceleration, this cupula is basically like a paddle, and it can sense when fluid is moving because it tilts as fluid moves past. It's a small elevation within each of the three semicircular ducts. Anterior, posterior, and horizontal ducts detect different movements. Hair cells covered with the cupula of gelatinous material. So again, instead of crystals here, we just have this big gelatinous cupula and these hairs inside of it. When the cupula bends one way, one signal is generated. When it bends the other way, another signal is generated. And when you rotate and spin in a certain way, the fluid starts rushing past. Now, why is that the case? Well, if you ever take a cup containing a liquid and turn it quickly, the liquid stays still, at least until you turn it lots and lots and lots. Now, the same thing happens in your head. When you turn your head quickly, the liquid inside your head stays still, but because the whole head is turning and the liquid staying still, it's interpreted as fluid rushing past, which bends the cupula, and we sense rotational acceleration. If we keep spinning for long enough, the liquid catches up and we stop feeling the spin. But then if we get off the spinning object, we feel it again because now we've stopped our head. The liquid is still moving because it caught up with our head, and it starts flowing past this again, and we feel the spin again. So when your head in still position, when your head is rotating, the fluid rushes past, and it sends one kind of signal for fluid going this way. When the fluid goes the opposite way, another signal is sent, meaning rotating in the opposite direction. Okay, that is the end of that one. And I think we have one more. Oh, we have two more. My goodness. Folks, we have a long one. Sorry about this. Next is endocrine. I think I overdid this one module. So I do apologize for putting so much in this one module. Later modules have a little bit less per week. So just do the best you can with this one. And we'll keep going. So our next chapter is chapter 21, endocrine. It's a little bit less intense. So hopefully we'll go a little bit more quickly. Okay, so on to chapter 20. Okay, the endocrine system. The endocrine system and the nervous system often work together to bring about homeostasis, which means keeping things in balance. Both use specific communication methods and affect specific target organs. The endocrine system is slower, the nervous system is quicker. Their methods and effects differ. Okay, this is a really great image showing you all the different organs of the endocrine system and what each produces. So take a look at this. It gives you a really nice overview of the endocrine system and the hormones produced by each of these organs. Exocrine glands, the secretions are released onto ducts opening onto an epithelial surface. So for example, sweat is a good example of an exocrine gland. Endocrine glands are ductless organs that secrete their molecules directly into the bloodstream. So endocrine means inside, exocrine means outside. All endocrine cells are located within highly vascularized areas to ensure their products enter the bloodstream immediately. So endocrine glands do not have ducts. Only exocrine glands do because they have to penetrate something like an epidermis, which is thick. So the living cells are down below, the surface is way above, and you need a duct passing through the dead tissue. Hormones. What are hormones? They're molecules that have an effect on a specific organ or cell. Only cells with specific receptors or places to grab hold of that hormone respond to that hormone. They're called target cells if they can respond to a particular hormone. So the target cell for a hormone is a cell that contains the receptors that would bind the hormone, cause a physiological reaction inside the cell. Organs, tissues, or cells lacking the specific receptor do not respond to its stimulating effects. So if a cell or an organ does not have a receptor for a hormone and the hormone's there, it's not going to affect that cell at all. Some classification of hormones. Peptide hormones. They're formed from short chains of amino acids. Most of our body's hormones are peptide hormones. So this is a short chain of amino acids. Because the amino acids are joined together with peptide bonds, these are called peptide hormones because they're a string of peptide bonds. Longer chains are called protein hormones. So if they go from a short chain to a long chain, they're called protein hormones. One example is growth hormones. That's a peptide hormone. So really a protein hormone is still a type of peptide hormone. Steroid hormones, which get the most press, are a type of lipid derived from cholesterol, things like testosterone and other hormones that help us grow muscle. Testosterone is a good example. Biogenic amines comes from the term that is a single amino acid that is converted into a hormone by changing the amino acid. So if you alter the structure of a specific amino acid in a very minor way, it becomes what is called a biogenic amine. And this is one amino acid that's been converted into a hormone. Thyroid hormone is a good example of that. T3, T4, or both. Biogenic. Excuse me. Still getting over, believe it or not, that cold that I had weeks ago. Okay, what is a negative feedback loop? Well, when a stimulus starts a process and eventually either the hormone is secreted or product of its effect cause the process to slow down or turn off. So the basics. We're sitting at a particular physiological level, whatever it is. If our physiological layer goes away from normal, that signals the body to do something to get us back to normal. When your body does that thing and gets us back to normal, the signal is sent to stop doing that adjustment mechanism. And so negative feedback means you don't need to do this anymore because we're back to normal. So negative means stop doing this process because we made our way back to normal. Negative feedback feeds back negatively, saying stop because we've gotten back to our normal, homeostatic, or normal level. Many hormonal systems work by negative feedback mechanisms. So they stay stable, they go away from normal. Something happens to put them back, and then the system shuts off. One example is the regulation of blood glucose levels in the body. So how does this work? Well, If you go away from normal, one of the ways to go away from normal blood sugar is to eat something containing sugar. So for example, the bun is flour. Flour contains starch. Starch contains sugar. And as we digest it, sugar is released. And what happens is blood sugar rises. That's a stimulus to the pancreas to release insulin. The insulin helps us move sugar from our blood into our body cells. When we have moved the sugar from our blood into our liver and our muscles, and we get back to normal, signal is sent back to the pancreas saying, hey, no increase in blood sugar, you can stop. Negative feedback, we're stopping this change because we're back to normal. And this goes away from normal because we did something like eating meat. Positive feedback loop is the opposite. So that is when something starts to happen that causes it to happen even more because we're trying to do something physiologically that's way different from normal. So instead of being at normal and you get pushed away from normal and getting right back, when you get out of normal, you want to do something significant, major, away from normal, and then get back to normal. So for example, if a woman is holding a baby inside of her uterus, normal is to keep it there. But when delivery, contractions start, you don't want to go back to normal, which is baby inside. You want to go away from normal, which is delivering the baby. So that becomes a positive feedback where a little bit of the stimulus leads to more and more and more stimulus until a major event occurs, the baby's delivered, and then you get back to normal, which is no baby. The idea here is it accelerates the original process either to ensure that the pathway continues to run or speeds up its activities. So a small amount of contractions causes even greater contractions later during childbirth. A few positive feedback loops occur in the human endocrine system. One example is the process of milk release from the mammary glands, as well as childbirth. So baby sucks the nipple, sends a signal to the hypothalamus, and this whole system continues the positive feedback loop until the baby is done, and then milk stops. Even better example is childbirth, but this is a good one. Hypothalamic control of the endocrine system. As the master control center of the endocrine system, the hypothalamus oversees most endocrine activity. Special cells in the hypothalamus secrete hormones that influence the secretory activity of the anterior pituitary gland. So one of the main jobs of the hypothalamus is to affect the anterior pituitary. They're called regulatory hormones because they are secreted into the blood to regulate secretion of most anterior pituitary hormones. So their job is to tell the anterior pituitary, what to do. They're called releasing hormones because they cause something else to be released. Inhibiting hormones means don't release anymore, stop releasing. The hypothalamus has indirect control over these endocrine organs because the hypothalamus controls the pituitary and the pituitary controls almost all the rest of the endocrine glands in the body. Hypothalamus produces two hormones that are transported to and stored in the posterior pituitary. Now, posterior pituitary is different. Posterior pituitary stores hormones from the hypothalamus and waits for a signal. Whereas the anterior pituitary makes its own hormones and is waiting for a hormonal signal to release it. In the posterior pituitary, the hormones move down through the infundibulum and are stored there until a until a signal from the hypothalamus tells them to be released. It may not seem like a big difference, but physiologically, very different between anterior and posterior pituitary. Oxytocin, which is involved in childbirth, ADH, antidiuretic hormone, which is involved in water balance. The hypothalamus directly oversees the stimulation and hormone secretion of the adrenal medulla, which is the center of your adrenal glands, or suprarenal glands is the words I was looking for. The glands that sit right on top of your kidneys. It's an endocrine structure that secretes its hormones in response to stimulation by the sympathetic nervous system. This would be stimulated if you're in a fight or flight situation, if you feel like your life is threatened. Some endocrine cells are not under direct control of the hypothalamus. And this shows you some of the mechanisms associated with it. This is showing you the adrenal medulla and sympathetic preganglionic axons coming down there when a signal from your brain comes in and says, hey, release epinephrine and norepinephrine, sometimes called adrenaline. It can increase your ability to react in a way that will save your life, increasing blood glucose, increasing alertness so that you can fight or flight, run or fight. The pituitary gland, sometimes called the hypophysis, lies inferior to the hypothalamus. It's a small, slightly oval gland housed within the hypophyseal fossa of the sphenoid bone. It's a little indentation of the sphenoid. It's covered superiorly by the diaphragma sellae, which we covered earlier in this class, which is one of the cranial dural septa that I mentioned, and ensheathes the stalk of the infundibulum to restrict pituitary gland movement. Connected to the hypothalamus by a thin stalk, the infundibulum. So we're talking about the pituitary. Partitioned both structurally and functionally into anterior pituitary and posterior pituitary. Remember, anterior makes its own hormones and waits for a hormone from the hypothalamus, whereas the posterior pituitary only stores hormones from the hypothalamus and is released due to an action potential coming from that. They're called the anterior lobes and posterior lobes of the pituitary. So you can see here the anterior pituitary is kind of a lighter color, posterior a darker color, not really that different. In reality, they accentuate the difference in color, make it more clear. And each of these has different regions that are shown here by this figure. Okay, the anterior pituitary is controlled by regulatory hormones secreted by the hypothalamus, as I mentioned. Hormones reach the anterior pituitary via the hypophyseal portal system. That's a big word. How do you pronounce something like that? Remember, take it in chunks. Hypophyseal portal system. So it's a hypophyseal portal system. What is a portal system? It's basically a set of blood vessels. Instead of going from the heart to a tissue or back to the heart, it's going from one capillary bed to the other. And in this case, it's going from the capillary bed in the hypothalamus to a capillary bed in the anterior pituitary. So very tiny amounts of hormone only have to travel a short distance and can go right into the anterior pituitary, telling it, hey, you need to release another hormone. It's essentially a shunt or a little tube that takes venous blood carrying regulatory hormones from the hypothalamus directly to the anterior pituitary before the blood returns to the heart. And this allows very tiny amounts of hormone to have a big effect on the anterior pituitary without going into the general circulation. And this shows you anatomically how it works. This also shows you what some of the glands that are affected by the anterior pituitary are: thyroid, mammary gland, adrenal gland. Growth hormone affects both adipose and muscle, reproductive hormones, and melanocyte stimulating hormone, MSH, and some of the hormones that the anterior pituitary produces. Thyroid gland, located right here in your neck, located immediately inferior to the thyroid cartilage of the larynx and anterior to the trachea. It has a distinctive butterfly shape due to its left and right lobes, which are connected at the anterior midline by a narrow isthmus. Both lobes of the thyroid gland are highly vascularized, meaning lots of blood vessels, giving it a reddish color. Regulation of thyroid hormone secretion depends upon a complex thyroid gland, pituitary gland negative feedback process. So for example, when you need to do something, the pituitary sends a signal, thyroid does it. When you get back to normal, the signal is sent back to the pituitary saying, you did this thing, so you can stop sending a signal. And here's a picture showing you the thyroid gland on the front of your trachea. This shows you some of the cells found within thyroid gland. This shows you some of the feedback loops. This is more physiological than anything, and I will not be testing this. Don't worry about this. Parathyroid glands. Small brownish red glands located on the posterior surface of the thyroid. Usually 4 small nodules, but some individuals have 2 or some have 6. 2 different types of cells in the parathyroid. chief cells and oxyphil cells. Chief cells are producing a hormone called PTH, or parathyroid hormone. It stimulates osteoclasts to reabsorb bone and release calcium ions. So when this is produced, it means your calcium levels are low. You need to take it away from your bone so you can use it in places like blood clotting, nerve transmission, and muscle contraction. Stimulates calcitrol hormone synthesis in the kidney, which helps you absorb calcium from food more. There we go. Prevents the loss of calcium ions during the formation of urine. Basically, this whole system is set up to help increase and maintain calcium levels in the blood. Function of oxyphil cells is not as important. These are the parathyroid glands on the back of the thyroid gland. And these are some of the cells that make up that tissue. Here's another feedback loop. I'm not going to be asking you about it, but it does show you how calcium ions and PTH molecules interact with each other to help maintain blood calcium levels. Adrenal glands, or suprarenal glands, sitting right on top of your renal kidneys. They're paired, pyramid-shaped endocrine glands that are anchored on the superior surface of each kidney. They are retroperitoneal, which means behind the peritoneum, and that means that they're pressed against the body wall and don't move. Minimize their movement to reduce any kind of damage that would happen during exercise. The outer adrenal cortex and inner central core are called the adrenal medulla. So the cortex, outer, medulla, central, we saw that in the brain. They secrete different types of hormones. Adrenal cortex is yellowish because of the stored lipids in its cells. It synthesizes more than 25 different steroid hormones, collectively called corticosteroids. So cortico comes from cortex, steroids meaning they are lipid-based. Corticosteroid synthesis is stimulated by ACTH, produced by the anterior pituitary. So remember, the hypothalamus would stimulate the pituitary would stimulate the adrenal cortex, and some of these corticosteroids that would then be released, sometimes referred to as stress hormones. Not all of them, many of them are stress hormones. Corticosteroids are vital to our survival, trauma, or removal. The adrenal glands requires corticosteroid supplementation throughout life. Partitioned into the zona glomerulosa, the zona fasciculata, and the zona reticularis. Different functional categories of steroid hormones are synthesized and secreted in the separate zones. They regulate salt, sugar, and sex. I'll put the exclamation. Okay, these are the suprarenal glands, having an outer cortex and inner medulla, and this is what they would look like if you looked inside of a person. Now, not exactly, but their colors are exaggerated to make it clear. This is what it would look like in a cadaver. There's the adrenal or suprarenal glands. And this shows you the different regions of the adrenal glands. The glomerulosa is more cortical or cortex-based. And as you get way down here, the adrenal medulla has these different cells in different colors when stained. Adrenal medulla forms the inner core of each adrenal gland. Pronounced red-brown coloration due to extensive vascularization, blood vessels. Primarily consists of clusters of large spherical cells called chromatin cells. When innervated by the sympathetic division of the autonomic nervous system, one population of cells secretes the hormone epinephrine, or adrenaline. What this does is it makes you ready to fight or flee. The other population secretes the hormone norepinephrine, or noradrenaline, which has other effects. Hormones work with the sympathetic nervous system to prepare the body for an emergency or fight or flight situation. Your pancreas, which is responsible for blood sugar balance. Elongated, spongy, nodular organ situated between the duodenum, the small intestine, and the spleen, and posterior to the stomach. So this area right above your stomach, between your stomach and small intestine. It has both exocrine and endocrine activities. Thus is considered a heterocrine, mixed gland, heterocrine gland. Mostly composed of cells called pancreatic acini. They produce an alkaline pancreatic juice that aids digestion. Now, why alkaline, which means basic? It basically is there, is there to counteract the acid that comes from the stomach. So the the juice that comes from your pancreas is there to neutralize the stomach acid, because the digestion that occurs in your small intestine generally is done at a neutral or slightly basic level. Scattered among the pancreatic acini are small clusters of endocrine cells called the pancreatic islets, or islets of Langerhans, and they're composed of 4 types of cells. 2 major types called alpha cells and beta cells, 2 minor types called delta cells and F cells. Each type produces its own hormone. More about the pancreas. The alpha cells secrete glucagon, which is produced when blood glucose levels drop, and this causes blood sugar levels to rise between meals. Beta cells secrete insulin when blood sugar levels are elevated. So when you eat a meal and the blood sugar goes up, the job of insulin is to get it back to normal. And when your blood sugar drops, the job of glucagon is to get it back up to normal by releasing sugar from your muscle cells and especially your liver. Delta cells are stimulated by high levels of nutrients in the bloodstream. They synthesize somatostatin, also described as growth hormone inhibiting hormone, or GHIH, which slows the release of insulin and glucagon and slows the rate of nutrient entry into the bloodstream. So if you have too much nutrients, basically you slow down absorption of it. F cells are stimulated by protein digestion, and they secrete pancreatic polypeptide to suppress and regulate somatostatin secretion from the delta cells. Getting kind of complicated, more physiological than anatomical. Pancreatic hormones provide for the orderly uptake and processing of nutrients. That's in red, because that's really what the pancreas does. Helps you bring in nutrients, process them, and maintain blood sugar levels. So your pancreas is very, very important. And there's where it sits. There's your small intestine. There's your spleen. There's a blood vessel. The stomach will be sitting right on top of it. These are some of the cells found within the pancreas. Pineal gland found in your brain. Pineal gland, or pineal body, is a small cone-shaped structure attached to the posterior region of epithalamus, which is behind the thalamus. It secretes melatonin. You may have seen this in supplements. It helps you fall asleep. Helps regulate a circadian rhythm, or 24-hour body clock. So when you produce more melatonin, it makes you sleepy. When you produce less, it makes you more wakeful. It also appears to affect the synthesis of the hypothalamic regulatory hormone responsible for FSH, which is follicle stimulating hormone, and LH, luteinizing hormone synthesis. Role in sexual maturation is not very well understood, but it does have an effect. Thymus, bilobe structure located within the mediastinum, superior to the heart, and immediately posterior to the sternum, so it's right behind breastbone. Size of the thymus varies between individuals. It's always relatively large in infants and children because it has a greater function in immunity as a child than it does as an adult. As with the pineal gland, the thymus diminishes in size and activity with age, especially after puberty. Functions principally in association with the lymphatic system to regulate and maintain body immunity. It's the location for many white blood cells to mature and become ready to work as active cells that would fight infection. Produces complementary hormones thymopoietin and thymosins. These hormones act by stimulating and promoting the differentiation, growth, and maturation of a category of lymphocytes called T lymphocytes. And T means thymus-derived lymphocytes. So they're derived from the thymus and they mature there. Organs of the urinary, cardiovascular, digestive, and reproductive systems contain their own endocrine cells, which secrete their own hormones. They help regulate electrolyte levels in the blood, red blood cell production, blood volume, and blood pressure are also regulated by these hormones. Digestive system activities are regulated. Sexual maturation and activity are regulated. Secretory activity of endocrine gland wanes in old age, especially secretion of growth hormone and sex hormones. It's part of the reason why older folks often have less sex drive as they age. Reduction in GH, or growth hormone levels, lead to a loss of weight and body mass, sometimes, but not always. Testosterone, or estrogen levels decline. Now, this is very different in men and women. Testosterone levels in men decline gradually as with age, and estrogen levels drop off precipitously after a woman stops ovulating. Okay, that's that. And last but not least, we have chapter 21, blood. So we're going to do that quickly and then call it a day. Okay, blood. What is blood for? Well, it transports things like oxygen, CO2, metabolic wastes, nutrients, heat, and hormones. Blood regulates certain things. It helps regulate pH through buffers. It helps regulate body temperature. That is, if you need heat in a place, you send more blood there. Or if you need to dump heat, you send blood to the skin where it dumps excess heat. If you want to retain heat, you send blood towards the core. It helps regulate water content of the cells by interactions with dissolved ions and proteins, and helps you be protected from disease by the white blood cells and loss of blood through the platelets. Okay, what are some components of blood? 55% plasma and 45% cells. Now remember, plasma is mostly water. So what is your blood mostly made of? Water. 45% cells, approximately 99% of those cells are red blood cells, less than 1% are white blood cells and platelets. So you can see the divisions here of the different aspects of blood. Blood plasma is over 90% water, 7% plasma proteins. Those plasma proteins include albumin, which is the same albumin that you find in egg whites, chicken egg whites. It helps maintain blood osmotic pressure. The details of that I'll get to in physiology. Globulins or immunoglobulins are antibodies that bind to foreign substances and invading microorganisms, which contain molecules called antigens. So these antigens are proteins found on the surface of foreign invaders, and the antibodies, immunoglobulins, stick to that marking for destruction. They form antigen-antibody complexes, which white blood cells then target and destroy anything that has that complex. Fibrinogen is a protein used for clotting your blood when you are cut. What are some formed elements, or sometimes called cellular elements? Well, red blood cells, the scientific term is erythrocyte. White blood cells, scientific term is leukocyte. Different types of leukocytes include granular leukocytes, named if you look at the picture, because the granules are visible when stained. So granular leukocytes that contain these granules are neutrophils, eosinophils, and basophils. Agranular leukocytes include lymphocytes, which are T cells, B cells, and natural killer cells, or NK cells. And monocytes are also agranular leukocytes. And last but not least are platelets, which are special cell fragments involved in blood clotting. Hematocrit, what is this? It's a measure of the percentage of blood occupied by cells. So the more cells you have in your blood, the higher your hematocrit. If your level of blood cells is low, you have what is called anemia. There's not enough red blood cells or not enough hemoglobin. But I will let you know that lack of iron is not the only cause of anemia, lots of causes. If you have too many blood cells, it's called polycythemia, and there's too many red blood cells, over 65%. What could cause this? Dehydration, loss of water would mean increasing the relative percentage of cells because you've lost the plasma portion. Tissue hypoxia, that is regularly training in low oxygen conditions like at altitude, can give you more cells containing and carrying more oxygen. Blood doping in athletes, sometimes blood will be separated from its plasma and then the cells will be put back into the athlete. I think Lance Armstrong got in trouble for that. That's one way to get your number of cells higher. You can carry more oxygen. How's blood formed? Most blood cell types need to be continually replaced. Many die within hours, days, or weeks of formation. The process of blood cell formation is called hematopoiesis or hemopoiesis. These are both correct terms. So remember, on a test, could be two right answers there. It occurs only in red bone marrow of flat bones like sternum, ribs, skull, and pelvis, and at the ends of long bones in the area called the epiphysis, where you find red bone marrow. If you look at an individual red blood cell, it looks kind of like a candy called Werther's. They contain oxygen-carrying protein called hemoglobin that gives blood its red color. Approximately 1/3 of the cell's weight is hemoglobin. Biconcave means indented both top and bottom, so you can see biconcave indented on both sides. About 8 microns in diameter, very tiny. The increased surface area to volume ratio is due to this indentation. Flexible shape for narrow passages, and it has no nucleus or other organelles. One of the reasons why I don't really consider red blood cells true cells, because body cells normally have a nucleus that allows it to divide and pair. Red blood cells are really just bags of hemoglobin. Should not be called cells at all, but they are. There's no cell division or mitochondrial ATP formation because there's no nucleus. Basically, all they are is just a bag of hemoglobin. Some chemical processes occur in there, but very little. The life cycle of a red blood cell. Red blood cells live only about 120 days. Now, in the test, I might say 4 months. So don't freak out, because 4 months and 120 days, same thing if you do the math. They wear out from bending to fit through capillaries. Also, the inside of some capillaries are rough, causing damage. And because red blood cells have no nucleus and repair mechanism, they have to be recycled out rather than repaired. Their worn out cells are removed by fixed macrophages, which are white blood cells, in the spleen and liver, which basically check red blood cells regularly. And if they seem damaged, they get pulled out, destroyed, and the chemicals within them get recycled. Breakdown products are recycled. Some parts are recycled to go out where the proteins are, but the heme portion of it becomes part of your bile in your gallbladder. It's kind of a weird, why do you move stuff from the red blood cell to the gallbladder? That's how your body does it. White blood cell anatomy and types. All white blood cells or leukocytes have a nucleus and no hemoglobin. So they are true cells, and they contain DNA, which is what, when we get blood, what we test. Because red blood cells don't have DNA, we have to test the white blood cells in the blood. Granular or agranular classification is based on the presence of cytoplasmic granules made visible by staining, as I mentioned earlier. White blood cell physiology. They're much less numerous than red blood cells. There's about 1 white blood cell for every 700 red blood cells, less than 1%. Leukocytosis is a high white blood cell count, which can be due to infection or strenuous exercise can cause more white blood cells. Leukopenia is low white blood cell count due to radiation, shock, or chemotherapy. Now, leukocytosis and leukemia are different. Leukemia is officially a type of leukocytosis. Leukemia is due to the presence of high numbers of immature white blood cells, not mature white blood cells. In the truest case of leukocytosis, these would be properly formed white blood cells. CBC. When you get a CBC, it screens for anemia and infection, total red blood cells, white blood cells, and platelet counts, differential white blood cells, sometimes called DIF, hematocrit, and hemoglobin measurements come as a result of the CBC. Normal hemoglobin range for most adults is 12 to 18 grams per 100 milliliters of blood. Okay, how do platelets work? Well, platelets are here and they normally don't stick to the inside of blood vessels. Platelets stick to exposed collagen underlying damaged endothelial cells in a vessel wall. So when a vessel wall gets damaged, collagen becomes exposed and the platelets start to stick to it. This is the beginning of the clotting process. Blood drawn from the body thickens into a gel. Normally, if it's not moving, it's kind of like cement. Cement stays liquid if you keep turning it, but as soon as you stop turning it, it starts to solidify. Same thing with blood. Blood stays liquid if it's moving through blood vessels, and as soon as you let it sit, it starts to coagulate, unless you mix it with a chemical called heparin, which allows it to remain liquid. If clotting occurs in an unbroken vessel, this is called thrombosis, and this is what you don't want to have because you don't want blood to clot in an undamaged blood vessel. A blood clot can come loose, get lodged in your heart or lungs or brain, and cause a stroke. Substances required for clotting are calcium, enzymes synthesized by liver cells, and substances released by platelets or damaged tissues. It's a chain reaction that we go into in detail in physiology. Role of vitamin K in clotting. So normal clotting requires adequate vitamin K. It's a vitamin. It's produced by bacteria in your large intestine. So having healthy bacteria in your large intestine is very important for your blood to clot. So making sure that your large intestine has healthy bacteria is important for overall health. Intravascular clotting, a thrombosis or clot forming an unbroken blood vessel is called a thrombosis. It can dissolve spontaneously or dislodge and travel. This is not good. Sometimes that happens when you're in a long airplane flight. Blood clot forms in your legs, comes loose when you stand up, it travels to your heart, lungs, or brain. You have a stroke, you can die. An embolus is different though. When a clot, air bubble, or fat from a broken bone is in the blood, that can also block a blood vessel because it gets stuck. Low-dose aspirin blocks synthesis of thromboxane A2 and reduces inappropriate clot formation. So some people in their middle ages will take low-dose aspirin, like baby aspirin, to reduce the formation of clots and therefore reduce the chance that the clot will move and get stuck somewhere. So some older folks like me would take it. I don't, but I probably should. Okay, blood groups and blood types. I'm not going to go into much detail in this because this is primarily physiological or physiology. So I'm going to present it here, but it's not going to be much on the test. So take a look, fill in your notes. Won't be much on the test, I don't think. ABO blood groups has to do with the presence of antigens called A and B. Take a look at this. I'm not going to talk about it in detail because it doesn't come up on the test much. Universal donors and recipients. Again, I'm not going to talk about this much because it's primarily physiology, but take a look, fill in your notes. It could potentially come up. Anemia, if you don't have enough red blood cells. What are some of the symptoms? Well, oxygen carrying capacity of blood is reduced. This is the description. What are some of the symptoms? Fatigue, that means loss of energy. Cold intolerance, that means you can't stand cold. And paleness, pale skin. What are some different types of anemia? The most common, or the most commonly believed to be, is called iron deficiency anemia. So it's a lack of absorption or loss of iron from the body. And let's go check something really quick. Sorry, folks. I hate to do this to you. Pernicious anemia is lack of intrinsic factor for B12 absorption. Hemorrhagic anemia, loss of red blood cells due to bleeding. So, for example, ulcers can lead to hemorrhagic anemia. Hemolytic anemia, defects in the cell membranes of red blood cells cause it to rupture, don't work well. Thalassemia is a hereditary deficiency of hemoglobin production. Aplastic anemia is the destruction of bone marrow due to radiation or toxins. Sickle cell anemia is a genetic defect in the production of the hemoglobin molecule. When there's low levels of oxygen in the blood, the red blood cells deform by changes in the hemoglobin molecule within the red blood cell. This only happens to people who are homozygous recessive for this rare genetic defect. Found among populations in the malaria belt, in Mediterranean Europe, sub-Saharan Africa, and Asia. So why does this gene exist? Well, it turns out by having just one gene for it, it can actually protect you against malaria. So it's not all bad. It's just mostly bad if you get 2 copies of it. A person with one sickle cell gene has increased resistance to malaria. And that's why this gene evolved and was retained, because malaria kills lots of people in certain areas of the world. And so by having just one copy of it protects you against malaria. 2 copies can give you sickle cell anemia. So for example, if you look at the areas in green here, this is where malaria is prevalent in the world. And if you look here in the red, pink, these are areas where the sickle cell gene is present, which evolved and was retained here because people who have one copy of the gene are resistant to malaria, which kills millions every year. Hemophilia is another inherited deficiency of the blood, but in this case, it's a deficiency of clotting factors. So when a person gets cut, they just continue to bleed and bleed and bleed. It's called hemophilia because hemo means blood, philia means lover. These are blood lovers. That is, they need blood transfusions to get the clotting factors they need to keep from dying, blood loss. Sometimes spontaneous bleeding can occur, or even after very minor traumas. Nosebleeds, blood in the urine, articular bleeding, and pain are common. Treatment is transfusions of fresh plasma concentrates in the missing clotting factor. Leukemia, as I mentioned, acute leukemia is uncontrolled production of immature leukocytes. Now, mature leukocytes fight infection. Immature leukocytes don't do anything other than take up room in your blood, crowding out red blood cells, making it harder for you to carry oxygen. It prevents production of red blood cells and platelets if there's too many white blood cells. In chronic leukemia, accumulation of mature white blood cells in the bloodstream because they do not die. This is the less common, this is the more common. Acute leukemia actually kills lots of people. Usually, if you kill the bone marrow that produces these immature leukocytes and then give non-cancerous bone marrow injections or transplants, it can solve that problem of overproduction of immature white blood cells. Okay, that is it for today. It was a major slog. I appreciate you guys sticking with it. Get all your notes filled in. Email me with any questions. Best of luck, and I'll see you next time. Bye, folks.